If you're enjoying this Med Prep to Go Step 1 podcast, you can now get the content along with the content of the Crush Step 1 podcast ad-free in one bundle. Just go to medprep2go.com and find our new subscription podcast called Med Prep to Go Step 1 Bundle.
When the holidays start to feel a bit repetitive, reach for a Sprite Winter Spiced Cranberry and put your twist on tradition. A bold cranberry and winter spice flavor fusion, Sprite Winter Spiced Cranberry is a refreshing way to shake things up this sipping season. And only for a limited time. Sprite, obey your thirst.
This episode is brought to you by Indeed. You're ready to move your business forward, but first you need to find the right team. Start your search with Indeed Sponsored Jobs. It can help you reach qualified candidates fast, ensuring your listing is the first one they see. According to Indeed data, sponsored jobs are 90% more likely to report a hire than non-sponsored jobs. See the results for yourself. Get a $75 sponsored job credit at Indeed.com/podcast. Terms and conditions apply.
Every who down in Who Newville liked the holidays a ton, but where to get great prices on gifts they had no idea. None. They searched and they searched for great gifts under $25. Gifts for spouses and friends and even their toddlers. When suddenly one who shouted, Walmart has what you want, knowing they have Lego, Tree Hut, and low prices to flaunt. So they enjoy the holiday season as who's often do. Cheering and shouting, Walmart has incredible gifts. Who knew? Find gifts they'll love under $25 at Walmart.
Hi, I'm Dr. Raj, and this is the Med Prep to Go podcast. So I'm going to be reviewing 3 USMLE Step 1 questions. And you know what? The topic for tonight is going to be pathology. So for more questions, check out our website, which is going to be medprep2go.com. It's a free audio and online question bank. And to learn more about me, why don't you check out my own podcast? It's called Beyond the Pearls, which is the name of my book series published by Elsevier. There's going to be the morning report Beyond the Pearls, which is for clinical medicine, steps 2 and 3, and my case reports Beyond the Pearls, which is going to be the basic science geared to step 1. Definitely check me out on social media, you name it. I'm all over that. And I think that's about it. So let's get to those questions. For pathology, the first one's going to be a 17-year-old girl presents to the clinic with a complaint of difficulty swallowing food for the past 2 weeks. So what is that called? Dysphagia. And you know me, I'm always dropping pearls everywhere. When we talk about dysphagia, there are 2 main types. There's going to be transport dysphagia and transfer dysphagia. Transfer dysphagia is the act of moving the food from the mouth to the back of the mouth. You know what I'm saying? While when we talk about, transport dysphagia is taking the food going down the esophagus all the way to the stomach. And it's been going on for 2 weeks, so not a long time, and she is on the younger side. So she describes occasional episodes where the food seems to get stuck in my throat. That's in quotes. This mostly occurs with solid foods and is sometimes associated with some vomiting and abdominal pain. So everyone, does age make a difference when you talk about dysphagia? Definitely. Because if you're going to be older and you have dysphagia, what do I worry about? Oh, of course, cancer, esophageal carcinoma, esophageal squamous cell, esophageal adenocarcinoma. But this is a 17-year-old who's had it for 2 weeks, so it's not going to be that, I hope. And she does not experience any urticaria or dyspnea with these episodes. She denies any heartburn or hematemesis or weight loss. You know what I mean? And of course, weight loss, you always think about esophageal carcinoma, but you know what else can give you dysphagia and give you weight loss? Achalasia. So that's just me dropping pearls. And she has no history of psychiatric illness. Her past medical history includes asthma and allergies to nuts and shellfish. So does that kind of relate to dysphagia? The fact that you seem to be allergic and all that stuff? Yeah, kind of. I'm not going to give away the answer, but it kind of does. She does not use alcohol or other drugs. So, of course, if you're drinking lots of alcohol, what type of esophageal cancer are you prone to? That's going to be something like squamous cell esophageal. Think of smoking and drinking and smoking. Her meds include albuterol. She has asthma. And she's on an oral contraceptive and an epinephrine auto-injector. So maybe she had an episode of anaphylaxis in the past. I don't know. Physical exam is unremarkable. She's referred to a GI doctor who recommends an EGD, upper endoscopy. Which of the following findings most likely be found when they perform the endoscopy? Is it A, esophageal varices? That sounds like a hokey pokey answer. So if you're going to have esophageal varices, throw out the magic word. Cirrhosis, right? It's going to be someone who has portal hypertension. Of course, there are other causes of varices, but I'm going to think if you have varices, you think about what? Bleeding. Oh man, variceal bleeds can be horrible. That's not this patient at 17, right? Esophageal webs can definitely give you dysphagia. Now, if I'm going to throw out some webs, you know what I'm saying? Give me some iron deficiency anemia. And who could tell me if you have esophageal webs and iron deficiency anemia, what syndrome is that called? That's called Plummer-Vincent syndrome. Also, sometimes people call it Patterson-Kelly syndrome, but I love calling it Plummer-Vincent. But, I don't see anemia anywhere in here, and you really need to evaluate just to call it esophageal webs on the scope. I'm not feeling it. Intestinal metaplasia, that seems to be odd with some of the things that she's talking about for the 2-week episode of difficulty swallowing. I don't know why I would think about intestinal metaplasia. Well, she didn't even have weight loss. I take it back. So I'm not feeling that. Linear furrows. What are linear furrows? I guess you'll see that on the scope. What is that associated with? So I'm not going to cross it out or rule it out just yet. Punched out ulcers. So, I guess if you're going to have a lot of ulcers in there, you got to think of the magic words dyspepsia. And probably you could think about some of this when you have someone who has maybe odynophagia, pain on swallowing, but I don't know. So the right answer here is going to be D, linear furrows. So linear furrows, along with esophageal rings, are a classic finding in eosinophilic esophagitis. So that's going to be what this patient probably has. Why? Because of the history of asthma. She's atopic. There's allergies. And really, when you throw the scope in there, that's one of the classic findings is going to be these linear furrows. And as mentioned, this is when you have eosinophilic esophagitis, you get the dysphagia, food impaction, and definitely that history of A to B. This patient has EOE, that's eosinophilic esophagitis, a disorder of eosinophilic infiltration of the esophageal mucosa. It's commonly found in patients with a history of atopy and can present with a wide variety of GI symptoms. It most commonly presents with dysphagia and food impaction. On endoscopy, esophageal rings can be noted. And rings and webs and rings are sometimes used interchangeably in a clinical sense. Obviously a ring is going to be concentric, involving all 3 layers of the mucosa, while a web will only most of the time partially occlude the esophagus. Webs tend to be more higher up in the esophagus, while rings tend to be more distal in the esophagus, just throwing it out there. Rings and linear furrows are often found in the right clinical setting with eosinophilic esophagitis. So answer choice A, esophageal varices is incorrect. Without a history of alcohol use or cirrhosis, there's no reason to suspect it. Varices are often asymptomatic until they rupture and you get painless hematemesis. Choice B, esophageal webs is incorrect. They often present with dysphagia from poorly chewed food with iron deficiency anemia. Now, in a Plummer-Vincent syndrome, look at me, I called it already. Her history lacks the findings suggestive of anemia, making this answer less likely. All right. Intestinal metaplasia is incorrect. Would be extremely unlikely for a 17-year-old to have intestinal metaplasia, which is something you'd see with Barrett's esophagus. And who gets a Barrett's esophagus? Long-standing what? Long-standing GERDs and heartburn and that stuff. Okay. And choice E, punched out ulcers, is incorrect because they may be found in many infections such as herpes simplex virus 1 esophagitis, and you'll probably end up having something like odynophagia, pain on swallowing. This patient has no history suggestive of HSV1. So learning points, linear furrows alone with esophageal rings are classic findings in the right clinical setting for eosinophilic esophagitis. Think of a patient that presents with dysphagia, typically has a history of asthma and atopy. What about this one? A 52-year-old woman presents to the clinic complaining of abdominal pain for the past 3 months. She describes epigastric pain with a dull gnawing and burning, that's in quotes, and the quality that improves after eating. She has had success treating it with antacids and has recently noticed that they have become less effective, meaning the antacids. She denies any chest pain, reflux, cough, hoarseness, hematemesis, melena, or weight loss. She endorses having some diarrhea. She has a history of rheumatoid arthritis. Her medications include methotrexate and some vitamin D. She does not drink alcohol or smoke cigarettes. Which of the following is the most likely etiology of her condition? So is it A, antibodies against intrinsic factor? Now, that's not a bad answer, because if you have a history of an autoimmune disease such as a rheumatoid arthritis, why not, have a history of what? Pernicious anemia, getting those antibodies, against those parietal cells. But once again, you would have physical complaints of being B12 deficient. I mean, throw me a bone, why don't you? Give me some neuropathy, give me some ataxia, why don't you? Throw me out some anemia, So I don't know. B, gastronoma. I mean, it's possible. I mean, gastronomas, are associated with something called Zollinger-Ellison syndrome that can present with some diarrhea. I mean, there's no weight loss there, nothing to indicate a pancreatic mass, but all right. C, gram-negative bacillus, that's catalase positive. What they're kind of hinting at here is they're probably hinting at maybe some H. pylori. That's not wrong to pick that. So gram-negative bacillus, that's catalase positive, urase positive, and oxidase negative. D, intestinal metaplasia, once again. Does she have, long-standing reflux? She's on antacids. I don't know. E, methotrexate. And I got to tell you, if you want to know what's my jam, I love talking about rheumatology. And methotrexate has a boatload of, side effects you need to worry about, but not, this epigastric, dull, gnawing, burning quality. It does give you some nausea, and, you have to slowly titrate up the drug. But I don't know. I really wouldn't think about this as the etiology. And the right answer is, B, gastronoma. So this patient's symptoms are most consistent with peptic ulcer disease secondary to a duodenal ulcer. These duodenal ulcers typically present with epigastric gnawing pain that improves with meals. The most common etiology, of course, is H. pylori, though it may rarely be due to a gastronoma. Zollinger-Ellison syndrome is characterized by gastric acid hypersecretion, resulting in severe acid-related peptic disease and diarrhea. Gastronoma is a rare cause of duodenal ulcers, but must be considered in the evaluation of a duodenal ulcer. And of course, when we talk about PUD, it can happen in the stomach, it can happen in the duodenum. And of course, in the stomach, you do worry about, the chance of it being cancer. You always want to biopsy and, make sure you're not missing something like a maltoma or that you may want to treat. Choice A is wrong. Antibodies against intrinsic factor is incorrect. Chronic autoimmune gastritis is an immune-mediated attack on intrinsic factor. Its most common presentation is pernicious anemia. Wow, look at Dr. Raj just calling it. Choice C, gram-negative bacillus, that is catalase positive, urase positive, and oxidase negative is incorrect. H. pylori is the most common cause of duodenal ulcers. However, it is a gram-negative rod. That's catalase positive, urase, oxidase is positive for catalase, urase, and oxidase, making C incorrect. So, wow, that was a little tricky one. You even got me on it. I thought they were totally thinking about H. pylori here and wondering why didn't they pick H. pylori. So the answer is wrong, because H. pylori is positive once again for catalase, urase, and oxidase. Okay. D, intestinal metaplasia is incorrect. Intestinal metaplasia in the stomach is indicative of an intestinal type gastric carcinoma without weight loss, systemic symptoms, no mention of risk factors such as H. pylori or type A blood. This answer is less likely. Methotrexate, choice C, is also wrong. Methotrexate can have GI side effects, like I mentioned, some nausea, maybe some loose stools, but not associated with PUD. And the learning point is duodenal ulcers typically present with epigastric gnawing pain that improves with meals and classically are painful 2 to 5 hours after a meal when acid is secreted in the absence of food for a buffer. The most common cause of a PUD definitely is going to be H. pylori, but you definitely want to think of non-steroidals. More rarely gastrinomas. Gastric ulcers typically worsen with eating and can be accompanied by postprandial belching, a sensation of epigastric fullness, early satiety. food intolerance, and sometimes vomiting.
Oh, Hilton stay, oh, Hilton stay. Your beds are soft and cozy. No lumpy couch, no stiff futon, no shower line at crack of dawn. Oh, Hilton stay, oh, Hilton stay. A holiday you're saving.
When you want holiday comfort you can count on, it matters where you stay. This season, enjoy spacious, comfortable rooms and friendly service when you book with Hilton instead. Hilton for the stay.
Hey, this is Bill Simmons from the Bill Simmons Podcast, here to tell you that Michelob Ultra, the official beer partner of the NBA, is bringing NBA fans closer than ever this season with chances to win great prizes, including courtside tickets. Enter now at michelobultra.com/courtside. Michelob Ultra courtside 25 to 26. No purchase necessary. Open to U.S. residents 21 plus. Begins on October 1st, 2025 and ends on June 30th, 2026. Multiple entry periods. See official rules at michelobultra.com/courtside for free entry deadlines, prizes, and details.
And our last one for today's podcast is a previously healthy 4-year-old boy with Down syndrome. It was brought to the physician by his mother because of foul-smelling discharge from the right nostril for the past 2 weeks. In this period, his mother has noticed the patient has had loud breathing while inhaling, which is not present before. His temperature is 98.6 Fahrenheit, heart rate is 90, respirations are 22, blood pressure is low at 90/60. Physical exam shows malodorous gray discharge in the right nasal cavity. Endoscopic examination of the nose confirms a diagnosis. Which of the following is the most likely diagnosis? Is this going to be allergic rhinitis? I don't know why it would just happen for 2 weeks, and why is it foul smelling? I'm not feeling it. Foreign body, when it's a 4-year-old kid, trust me, you'd be amazed what ends up in people's noses. Dr. Raj, while making this podcast, has a 3-year-old girl. Her name is Sadie, and oh my God, she is so cute. But I'm not joking. We found things up that nose. So I'm going to go with B without even reading the other choices. Don't do that on the regular exam. C, juvenile nasopharyngeal angiofibroma. Ooh, that's, I guess, but malodorous discharge, shortened time. It could be. I hope it's not, but I'm still going with B. D, nasal hematoma. Really not talking a lot about blood, but who knows? It's all about what the scope shows. And E, nasopharyngeal carcinoma. Another type of tumor. Why would it appear in 2 weeks? I'm going with B. Let's see what the right answer is. The correct answer is B, foreign body. Foreign body inserted into the nose can become lodged high in the nasal cavity or paranasal sinuses. This is a common cause of acute and chronic nasal symptoms in young kids, especially when the symptoms are unilateral. Foreign nasal bodies often present in a child as rhinorrhea and progress to infection with purulent malodorous discharge. These symptoms are isolated to the side of the foreign body, unlike sinusitis and upper respiratory tract infections, which can present with similar symptoms bilaterally. Diagnosis is made by direct visualization, and treatment consists of foreign body removal. Choice A, allergic rhinitis, is incorrect. Allergic rhinitis presents with sneezing and bilateral rhinorrhea, nasal obstruction, and is often accompanied by itching of the eyes, postnasal drip, giving a cough. Choice C, juvenile nasopharyngeal angiofibroma, is incorrect. It is a highly vascular but benign tumor that occurs primarily in adolescent males. So this kid's really young. That can cause epistaxis as well as problems as a result of local invasion of adjacent structures. Choice D, nasal hematoma, is also incorrect. A nasal or septal hematoma may result from trauma to the nasal septum. Blood collects in the space between the nasal cartilage and the overlying mucoperichondrium and can obstruct blood flow to the nasal cartilage, potentially resulting in a vascular necrosis of the nasal cartilage. And last but not least, choice E, nasopharyngeal carcinoma, is incorrect. Though nasopharyngeal carcinoma is the predominant tumor arising in the nasopharynx, it is rare in the United States and has a peak incidence of around people ages 50 to 59. So not really in the 4-year-old kid. So the learning point is foreign body in the nasal cavity is a frequent cause of unexplained unilateral nasal symptoms in young children. just like Dr. Raj's daughter. But anyways, I hope you enjoyed the 3 questions today. They are all high yield for the USMLE Step 1. And be sure to check out our website, which is medprep2go.com. See you again for more questions.
Hi, everyone. This is Ted O'Connell. I just want to let you know that we have launched a Step 2 QBank podcast, very similar to our Step 1 QBank podcast. Each episode will have 3 questions so that you can study on the go. We are actively recording these and plan to release a new episode every 2 weeks. We're also launching a premium podcast bundle that will include ad-free access to USMLE Step 2 Secrets podcast, as well as early and ad-free access to all of our episodes from the Step 2 QBank podcast. So please go over to our website at medprep2go.com and check these out, or you can access them wherever you get your podcasts. Thanks so much.